Okay, thank you very much. And again, welcome everyone. I'm very pleased to be moderating this panel on COVID-19 and early childhood mental health in Canada, fostering systems change and resilience. I'll just introduce myself briefly. So my name is Dr. Mary Bartram. I am the Policy Director with the Mental Health Commission of Canada, and will be working with a fantastic panel to both present the research from a policy brief which we've released and to discuss it from diverse perspectives. So before getting going, I just wanted to do a land acknowledgement and to acknowledge that both the Mental Health Commission of Canada and the Canadian Paediatric Society, who are our partners on this work, operate primarily on the unceded traditional territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. The Algonquin people have lived on this land as keepers and defenders of the Ottawa River watershed and its tributaries, and we are very privileged to benefit from their long history of welcoming many nations to this beautiful territory. And we also recognize the traditional lands across what is known as Canada, on which our staff and stakeholders and all of you reside. So in terms of the approach for today, I'm going to turn it over shortly to my colleague Brandon Hay, who will provide an overview of the policy research that informed a policy brief on this topic. And I will then invite our two panelists, Dr. Cassia Johnson and Corinne Bridger, to reflect on the findings from this research and some of the next steps for action and policy implications. And we'll finish up with time for question and answers, which I will moderate, and flag some important resources that you might want to access and how to do so. So that is pretty much the lay of the land in terms of the agenda. I'll just flag that the chat will be used to communicate with you more information, interesting links, and we'll also be opening up a poll shortly just to get a feel for who we have in the webinar, where people are from, and so forth. So without further ado, I will turn the mic to my dear colleague, Brandon Hay, whose expertise has been a driving force behind this work.
Thanks so much, Mary. I just wanted to flag for our tech support, we'll actually do the web poll after my overview of the brief. So try and go to the next slide. So I'm Brandon Hay. I'm a research policy analyst with the Mental Health Commission. I was one of the main authors of this policy brief, working in collaboration with Dr. Mary Bartram and our partners at the Canadian Paediatric Society. This brief was part of a larger series based on really looking at the kind of disproportionate mental health impacts of COVID-19 on various priority populations. This was something that emerged from an environmental scan that we had done in the first few weeks and months of the pandemic, and parents in early years population were identified as among those key populations. We worked in close collaboration with Leanne Boyd from the government of Manitoba and formerly from the Healthy Child Manitoba, as well as Dr. Robert Whitley from McGill University, Miranda Andrews from BC's Mental Health and Addiction, Dr. Doris Pear, who's a mainstay of the Brain Builders Lab work at the Canadian Centre for Substance Use and Addiction, as well as Dr. Daphne Korsak and Dr. Robin Williams, who are child psychiatrists and developmental pediatricians associated with the Canadian Paediatric Society. Following the initial work, we had some additional rounds of feedback and consultation engagement with the Public Health Agency of Canada, as well as the Canadian Academy of Child and Adolescent Psychiatry, who helped formulate our work further, as well endorse the final product. So as everyone on this call really knows, it's no surprise that COVID-19 has had a serious detrimental impact on the mental health of parents, children, and families. And many of these have been brought about the nature from lockdowns and quarantines on social isolation, disrupted access to critical needed social services and healthcare supports, including childcare and schools, financial worries and loss of employment, which we saw disproportionately affect equity-seeking groups, as well as different priority populations such as single mothers. We also saw kind of issues of housing precarity intersect with disaster planning around, different groups that use drugs, intersectional groups, those fleeing domestic violence, those sorts of things, as well as global increases in spousal and family conflict, which of course precursors to maltreatment risk and pose a threat in terms of adverse child experiences. Some polls indicated that rates of spousal conflict were as high as 49% in the earlier days and months of the pandemic. And all these stresses individually and together cumulatively and interact and compound risks for child development, for their social emotional development and learning, largely through changes, of course, in caregiver parent-child interactions. And these are really exemplified in many of the kind of facts and figures that were gleaned throughout the course of the pandemic, such as the 40% of parents in Ontario reporting social, emotional, behavioral challenges in their children, 3 to 4-fold increases in depression among mothers of infants and young children, such as those aged 18 months to 8 years. Global kind of cases across the country where parents were, a large share of them were very or extremely concerned about their ability to manage and cope with presenting mental health and behavioral challenges of their children. And also just putting this rate of distress in the context of pre-existing challenges, such as around kind of standardization and quality assurance in our early learning centers, which of course are bulwarks for promoting social emotional learning, at least in their optimal form. And these were something that have been largely an unrealized achievement, despite ongoing efforts to make improvements that have certainly were happening well before COVID began. So there's a lot going on here, but just this all to say that the prolonged cumulative compounding nature of the COVID-19 pandemic has created a confluence of stressors in community environments and home environments, resulting in spousal conflict, family violence, potential for parental separation, divorce, as well as the use of coping strategies that really impose threats to children's social emotional development through the emotional availability of their parents, their caregivers, and the kind of resources they have available or not to really be present with them in a way that's attentive to their need and attuned with their needs. And other pre-existing issues we really saw interact with COVID-19 stressors was really just kind of the state, as everyone on this call I'm sure is more than familiar and aware, the longstanding issues around accountability and quality of perinatal mental health services, long wait times for children's mental health services, the inadequacy of trained professionals in this regard, and the lack of accountability mechanisms to support access and quality access and standards. And this has really been, I think, detrimental to these populations for the course of the pandemic. And we did see different surveys where there was almost global consensus or recognition for the inadequacies of training available for health professionals in this regard, for early educators, as well as the availability of services, such as the integration of mental health in primary care, what have you, for perinatal 0 to 6, prenatal to 6 populations. And there's also been some potentially lost opportunity or disrupted opportunities to actually have early education centers serve as a hedge against developmental adversity caused by limitations in resource access for children growing up in poverty or in equity-seeking environments. And really the continued disruption of early education access has been really detrimental. Of course, necessary in some cases in context, given the nature and the uncertainty around the COVID-19 pandemic, but really also represented kind of some unintended consequences for what that means for children growing up in those environments, as well as their parents and caregivers who really rely on those supports to do things like get and maintain access to employment, which of course is a huge hedge against the risk for children's mental illness later. So the risks here are also really important in the context of what we know about brain plasticity and those crucial first few years. There's a lot of research on things like the Quebec ice storms, where mothers that were breastfeeding basically had their heightened cortisol transmitted through their breast milk, and then ending up in impacting the immune systems and the central nervous system development of their children, and the cortisol then being hyperactivated and secreted by toddlers themselves, later going on to predict kind of mental health status in adolescence. And extrapolating from that, what does COVID-19 mean in the context of a much greater population being affected over a much longer period of time, or some of the things we've learned about the epigenetic activation, about genetic vulnerabilities and child maltreatment. We've also seen, as I was mentioning, kind of the diminution or loss of different effective coping strategies through the loss of kind of social, emotional, and financial resources, leading different populations to turn to things like substances, cannabis, alcohol to cope with the degree and severity of stressors in their home and community environments. And this leading to the tragic and unfortunate likelihood of higher susceptibility to use kind of punitive approaches to parenting for maltreatment, and some of the cases where we are seeing young kids presenting to the emergency departments for injuries in places like Hamilton and Ottawa. And another piece that I kind of wanted to note was just, of course, recognizing that all these stressors have, of course, not been evenly distributed through the population. We've seen Indigenous parents, families worry disproportionately about the impacts of quarantine earlier in the pandemic at a rate of like 41% compared to non-Indigenous parents, as an example, as well as the disproportionate impacts of job loss and unemployment for single mothers, and what that really means in the context of heightening opportunities for parental stress and some of the kind of precursors that pose risk for child development and early childhood mental health. So what are our recommendations? Obviously, reducing parental stress, really having more targeted supports for this population, including better integration of perinatal mental health and developmental service providers in some of those settings that they live, work, learn, and play, such as primary care, expanding community outreach to foster social connection for those that have heightened propensity for isolation, as well as substance use or trauma exposure. We really know, and from the science, the importance of those connections in terms of reducing all those risks for helping people process and deal with trauma, bounce back from it, as well as reducing likelihood of child maltreatment. The importance of culturally safe mental health services and substance use supports for diverse, increasingly diverse parent populations and family structures that continue to represent a very broad, diverse kind of structures and demographics that I think really we need to do more segmented work around in terms of research, policy and service design, and policy development. And also recognizing the limitations and benefits of virtual services, which of course has been a great approach to addressing some of the inequities and problems in access, but I've also continued to pose challenges for people, say, below a certain socioeconomic bracket, as well as those who just aren't in an environment or place where they can have the confidentiality and the kind of safety that's really needed to foster things like a therapeutic alliance if they're in an environment that's, say, inherently unsafe. There's a lot to learn and glean also from the role that income support measures such as CERB might have likely played in diminishing likelihood for the onset and severity of things like child mental illness. And I'm sure that's something that will be studied in the months and years to come. Really seeing the need for affordable housing and shelter support, such as families that are fleeing domestic violence, and really recognizing that all the kind of factors contributing to parental stress we've seen through the course of the pandemic, not by any stretch of the imagination being equally experienced, really making sure with that any kind of policy development work, program system planning research really has explicit attention around the principles and use of sex and gender-based analysis, as well as any other identity markers around social identity and things that contribute to cumulative disadvantage as well as resiliency. Thank you.
Thank you very much, Brandon, for that overview. I hope people found it helpful, and would encourage people to find more information in a full brief that has been available in the links that have been provided, which I'll also reiterate at the end of the meeting today. So without further ado, I'm very pleased to be introducing our two panelists, Dr. Katya Johnson, who's a developmental pediatrician, a member of the Early Years Task Force, the physician lead for the Canadian Paediatric Society's anti-racism strategy, and a member of the Canadian Paediatric Society, as well as Corinne Bridger, who is affiliated with Parents for Children's Mental Health, the Windsor Essex chapter leader and founder of My Neurodivergent Child. And the full bios will be posted in the chat as well, so if you're looking for a little bit more information. So we're going to turn now to the panel discussion, and the way we're going to structure this is we'll ask Dr. Johnson and Corinne 3 questions and give each of them a chance to respond to the questions, and then we'll open things up to a Q&A. If you have questions, feel free to start posting them in the Q&A section, which you'll find at the bottom of your screen. And those will be brought together so that we can also open up questions at the end of the session. So just a few brief comments before we get started. Since we wrote this brief, we've certainly seen some improvements, easing of public health measures, although different in different parts of the country. Employment numbers have come back up considerably, but we still see that the rates of depression and anxiety across the population are very high and haven't really started to turn a corner. So the level of stress on parents continues to be high. So I'm going to start things off by asking Dr. Johnson and then Corinne, why is this work important to you? How are you involved in this work?
So first of all, thank you very much for having me here today. And I wanted to highlight something that was placed in the chat for everyone, is that a lot of the information presenting today may be triggering for us in the moment, in this hour, and may be triggering for people afterwards. And it's something to sit with that discomfort and wonder what that's about, but also reach out and find the help that we need, whether it's in our community or from other professionals. And there are some links that have been provided. And that kind of links to why this work is important to me. So I'm a developmental pediatrician, introduced as Dr. Johnson. So more than a job, it's a vocation, because there's the other part of me that's the mother of 2 little people. And a funny story of how am I involved in this work. My oldest noticed a change at school and came home and sort of commented to me, well, did you advocate for that change, Mummy? And sort of this question of, Mummy's an advocate for little people everywhere. So in my job and in my life and in my community and the research that we're doing. So involved in many different ways. And that really brings about the intersections of who I am as a physician, a parent, a family member, and a community member.
Thanks very much, Dr. Johnson. Corinne, why is this work important to you, and how are you involved in this work?
Yeah, so just to echo I'm very thankful for the Commission for opening up this discussion. So this work is important to me because, it impacts my family, and we have lived through this. So I'm a mom of 3 neurodivergent children. And, when we look at statistics pre-pandemic, and I don't know that we have any concrete, as we're coming out of it, but like 1 in 5 children, right, have mental health issues. And that doesn't come from nowhere. So obviously we need to back it up, and we need to be looking at, right from the beginning, right? How are we supporting new moms and new dads? And so that's why the work is important to me, because I found that support through peer-to-peer. So through PCMH and other local organizations that really empower parents through education and help to kind of, bridge that gap, and help parents to connect with other parents who have been through and understand, and kind of stave off some of that isolation. So that's why it's really important to me, and that's why I'm involved with organizations like PCMH.
Thanks very much, Corinne. We'll move on to our second question now, and that is, how and in what ways, and I'll start again with Dr. Johnson, do the highlights, issues articulated, and recommendations that Brandon reviewed relate to your work and/or lived experience?
So as a member of the CPS in the Early Years Task Force, I was also involved in the development of the policy brief, and I think the issues that are articulated and highlighted are those that many of us are living right now, whether it's through our lived experiences, as Corinne is highlighting for us today, and my own, but it's also the issues that we're seeing in the media. And it's sort of, I think, as you're joining a children's mental health space, I would imagine that many of us would agree that children were the silent voice in the pandemic, that need those adults around them, and to be listening to the youth, the adolescents, but need the adults around to be raising our voices, to articulate the experiences that have been quite traumatic and quite stressful with them, and ways that are not matters that change voting and change governments and change policy. And so I think that the recommendations relate to my desire to be an advocate for little people, and to be an advocate also for those populations that the pandemic has shown us. And as Corinne pointed out, we do have pre-pandemic data about children, but also about racialized communities and the effect of these concerns falling in different ways and with a higher burden in racialized communities. And so that's also part of the issues that are being articulated, and the importance to hear. And it's that those issues may be about the racialized communities, but they affect all of us and our general mental health as Canadians.
Thanks very much, Dr. Johnson. Corinne, how about you? How and in what ways do the highlights, issues articulated, and recommendations that Brandon reviewed relate to your work and your lived experience?
Yeah, so one of the things throughout the policy that was really apparent and really did stick out was the focus on, reducing parental stress. And that obviously, really coincides with my lived experience. And how do we do that? How do we alleviate some of that parental stress, right? So it's not a new conversation, right? And it's so sometimes it can be really frustrating, because although it was very needed and great to see all of the focus on mental health for parents who have actually been struggling with children's mental health for the last 10, 20 years. It was kind of like, okay, well, this is wonderful that now we're talking about this, right? So, how do we alleviate that parental stress? It really is, it can't be in isolation, and it needs to be part of the broader picture. And so sometimes that can be disheartening because it feels like you're kind of standing, at the void, screaming at all of the different systems that need to be focused on. But it's not just one thing, right? So we need to be informed in things like, trauma-informed care, and not looking at kids as having behavioral issues. Like, I really feel so strongly that, that day, gone are the days that we can just say, oh, this child has a behavioral issue, right? So it was highlighted in the policy that, children with behavioral issues is one of the main reasons why parents come forward and seek out help. And we see that all the time in our support groups. Parents, whether it's through early years or whether it's through school or whatnot, that, oh, I'm being told, my child has behavioral issues. So, what is that and where does that come from? And, how can we be supporting families so that they have the information that they need, that it's like not associated with all this shame, and that, they're bad parents and their kids are bad kids. And it's like, no, there's reasons why these things are happening. And it's not because your kid is having behavioral issues, right? So, sorry, I've gone off on a tangent there.
I'm seeing some nods from Dr. Johnson. She's relating, yeah. So was there more you wanted to say, Corinne, about that, or we'll leave it there for now?
No, we can leave it there for now. I guess we can loop back around if we have time.
Yeah. Okay. I mean, I'm certainly hearing, both of you speak to there were gaps in our understanding and resourcing of early childhood mental health, and the critical role of support for parents as an anchor for early childhood mental health. And that, the pandemic has just kind of, as it has for many things, just exacerbated and made more urgent the need to address those longstanding gaps and inequities. So the disproportionate way that those gaps fall on, whether it's on racialized communities or low-income folks, women and men in different ways as well, I think. So yeah, getting that kind of, both of you speaking to sort of, we knew this before, and during the pandemic, it's just become even more urgent, louder. The need to move on addressing some of the gaps in supports for parents and for families with younger kids at such a critical developmental stage, as Brandon discussed. So we'll just start in on our third question now. And this is where we really want to get a conversation going about the so what. So, what are the next steps that you see as most critical for translating these policy recommendations into further action, and what are the next steps for people in all different kinds of roles within society, whether it's people in communities, people in healthcare or mental health care roles or social service delivery roles, or people, policymakers, researchers. Feel free to tailor to those different audiences, because it's certainly not any one part of that mix, right? Everybody needs to be rowing together.
So Corinne, I want to go back at you a little there about that diagnostic term of behavioral problems. And what I say to parents is, as a developmental pediatrician, the giver of diagnoses, which is not really, it's the describer of child development, but behavior is communication. So when those kids are behaving in those ways, they're trying to communicate something that they don't have the words for. And I think sort of when we're talking about our translation of recommendations, people's behavior is saying saying the things that they can't say. I'm in distress. This is not working for me. I feel pain. I feel isolation. So I think little people only have certain ways they can say it. They kick, they punch, they bite, they swear, they flop, they stop listening, they run away, they laugh, they do all those things. So my primary thing is behavior is communication. And in that way, I think we have to focus on relational health. So for me, relational health is parent-child, parent-parent, parent-community. And I think the idea of relational health is that it mitigates stress, and it actually, we know from our research that it improves developmental outcomes. So how do we do that? So one of the recommendations that I know falls on a place of discomfort for myself also is that of screen time, good food, and getting out in nature. And I give every parent a lecture about that. And then I laugh and I say, and tonight my children will play Minecraft, and I will make sure that everyone eats a half a slice of cucumber. And, you know, we will be out in nature when we walk from the car into the house. And all of those things show my sign of privilege that there is a vegetable, that there is a car, and there's a house to enter. But when I go back to the idea of relational health, what it brings up is that emotional co-regulation, that parent-child opportunity to be together, to play, helps both regulate emotions. And the thing about co-regulation is when we can learn it in our calm times, we can use it in our tragic times, we can use it in our times of stress. So that may start with screen time and turn into, especially with little people, tickles on the couch, and then it turns into, you know, safe physical contact that helps us co-regulate. When heartbeats are close to one another, they come down. We know from neonates that are in the NICU and the little sort of boxes, when there's a parent stroking them, they have changes in their heart rate and their breathing rates. So that co-regulation is very primitive when we talk about the neonate and touch, but it stays there through childhood and into adulthood. And we need that safe touch. And when I'm talking about safe touch and appropriate touch, I think people can learn more about that, but really that is something to stress. But it's that idea of building relationships, co-regulating. And what that comes to when I'm talking to service providers is it's another term. So I've said behavior is communication. The other is, let's not fall into paralysis by analysis. Dr. Lee Ford Jones always talks about that. So one of the recommendations is about surveying and thinking. And for me, I understand that not to be, let's get paralyzed and collecting the numbers and not do. But for me, it's saying as a service provider, as a parent, you know, who is actually in my community? Who are we seeing coming into programs, and who are we not seeing coming into programs? And we know that there are certain groups, and whatever you want to, I'm, you know, as the physician lead of the anti-racism strategy, talk about racialized communities, but there are many other communities that have a social identity that don't feel comfortable in the spaces that we have created that are therapeutic and connective. So as service providers, we have to try and understand who we are not seeing, because many of those groups have support systems that may not fit into our traditional models of what parent-to-parent relational co-regulation looks like. And it may happen in different ways. And when we understand that, we can then fund and support it and grow it. Because why is, you know, the Somali autism parents group so strong and growing in Toronto is because suddenly there are parents, you know, that I'm meeting in Hamilton and Niagara and Guelph that are in these broader, you know, African communities that are saying people will understand what it means to me. And so that's a personal example, but it comes back to those ideas. And I'll say them one more time. Behavior is communication, emotional co-regulation. We have to see who we're seeing, but figure out who we're not seeing so that we don't get stuck in the paralysis by analysis.
Really interesting suggestions, Cassia or Dr. Johnson, on multiple levels in terms of some tips for parents around just looking for every opportunity for
play.
Yeah, for play, for that safe closeness as well, and for service providers to look carefully for who's not coming to the services and supports that are available and try to find where people are getting those supports. And then for policymakers as well, how do we support and resource those services as well, so that we're not just trying for a one-size-fits-all model, and we're really looking for how do we build community resilience in different modalities with different communities. And so that's fabulous. Corinne, I turn it over to you in terms of your thoughts about this question around some key next steps for translating some of that policy research into action at multiple levels, or at one level, as you wish.
Yeah, so one of the, I mean, the policy is has tons of great recommendations. So the one that I really kind of focused on was actually recommendation number 12, right? So I'm just going to read it out here. So to expand access to mental health first aid and peer support interventions for diverse parent populations and their 0 to 6-year-olds, right? So what we hear from families time and time again, because typically by the time families are connecting with PCMH, the children are older, right? Because they've now been through a couple of different systems, right? And now they're at the point where the parents are just like, I don't know what to do. I don't know, this is what the school is telling me, and this is what the psychologist is telling me, and this is what, they want to, put my child on medication, and I don't know what the medication is for, and I don't know what it does. And so they're really at that point of burnout, right? So they've been trying all of the things and none of the things are working. So the amount of family challenge and strife and frustration and crisis that can be averted if we just back it up, which is what we're talking about here, right? And right from the get-go in safe, non-judgmental, welcoming atmospheres, we are teaching parents about how to parent, about how to play, about how to connect, like we were just talking about, and what that looks like and what that feels like, because those parents themselves could have come from unsafe environments where they didn't learn those things. And so then now you're parenting and you're just going to repeat those cycles. Society has changed vastly in the last 100 years. We're not parenting in community. You don't always have grandma around. You don't always have, aunties and uncles around that can help take some of that burden, that can help, make life a little bit easier, right? Like parenting is hard. And when you have a child that has a mental health issue, it's even harder. So, and again, without too much of, every parent needs to be taught about, complex PTSD, and every parent needs to be taught about trauma-informed care, and because not every parent has the capacity for that, right? Again, showing my privilege that I've had time to learn and research. But, if I was a single mom living in the city, working 2 jobs, I wouldn't have time for that. So how are we going to meet parents where they're at, and in tangible ways communicate that we are a community that is going to support you? And I think that's one of the biggest things, right? That mental health is always dealt with in silos, in isolation, and it's not serving the whole family. It's not serving the whole person. It's not serving the whole child. And that just doesn't work. So that's where I would focus, is just serving the whole family.
Oh, that message comes through so loud and clear. And I didn't mention that I'm originally a family therapist, so this is all very consistent with my experience both in family therapy provision, but also, as a parent and as within my own family as well. And when we're thinking about supporting parents as a way of supporting young children, it's all very much part of the same system and also part of community systems as well. So the importance of seeing how all of these pieces fit together, and what that means in more practical terms. I think it's when we're providing support to adults that we're linking with the needs of their kids, right? And that when we're providing support to young children, that we're working with whole families as well, and siblings and so on. So really interesting, and the importance of providing that non-judgmental, meeting parents where they're at, opportunities for learning about parenting early on, I think, is another piece I heard very strongly from you, Corinne. So I'm just wondering if I can just ask, we've got a bit more time for one more question, and what's coming to mind for me, you've both spoken a little bit about your privilege. Part of the brief talks about more that kind of structural determinants of health around access to housing, access to shelter, access to shelter for families where there may be risk of domestic violence, for example, and income supports, as kind of taking more of that structural lens on. For policy, how important is that in terms of providing support to parents as we come through the pandemic, hopefully, at this point in time? Can you speak to and reflect on a little bit that the importance of those structural determinants of health pieces for policy?
So I think that the pandemic has obviously shone a light on things, but it should be, and it should have taught us, first lesson, that we are interconnected. So my privilege is connected to someone else's disadvantage. My privilege is connected to someone else's privilege. So I think when thinking about policy, the other thing is, as Corinne pointed out, is we've thought in silos. We fund here, and if you don't fit into this box or that box, then you fall between. And so a good example of what you brought up, Corinne, is my experience of, as a developmental pediatrician, seeing a child with behavioral concerns, whatever those are, whatever path we go on, but understanding that there is some relational health issue that is participating, not necessarily driving, but participating in what the child is presenting. But then I go to look to services, and services fund this diagnosis or this diagnosis, and they don't fund, or there's very small amount of funding to the relational family work. And so then it demands that the parents have private funding to be able to support this. And so for me, the policy space really has to start to see that, little people, exist in families that have various structures and people involved in what's considered their family. And that's built into communities. And for so long, we've had notions of what each one of those things look like. And then we've had, service agencies that compete for this section of the family, that section of the community. And then we're not meeting people where they are. Little people are, whether it's daycare, school, family, and community activities, that's where they live, that's where they work, that's where they function. So I think it's that coming together, and the changes you talk about, Corinne, that have happened in the 100 years, there was some good in that idea of the larger space and being together. And now we have to start to think about the dollars to do that. And it's going to look, there's not one definition, and it's going to take some reconciliation to understand how we've disrupted that with our colonial ideas. And we've disrupted that for everyone. And now we have to come together to think about how do we do this differently for different people? How do we support what people have the capacity? Parents are not behaving in this way because they want to. They often don't have opportunity, capacity, learning, opportunity, finances. And those are the things that have to come together. No longer the policy department for education and for health and for social services, but the policy department for little people that will become big people, that are living and loving with big people. And I think those are lots of fluffy words to say that policy now has to be like this, rather than like this and like this and like that.
So again, that need for a holistic approach, like joined up government kind of approach for.
And not one whole, but many wholes because of that diversity, right?
Okay. Excellent. Corinne, do you have any thoughts about this question of the importance of strengthening supports around income or housing or safe shelter?
Yes, so many thoughts. I'm loving everything I'm hearing. And again, I feel like in one sense, it's almost like preaching to the choir because, I can hear like, I get it and you guys get it. But unfortunately, the feedback that we get from families is that the people that they're dealing with don't get it. And that's not to say that, anyone goes into education or healthcare or mental health because they don't want to do good. No, these are all well-meaning, well-educated, competent people that want to serve families. But you do get to that point where your hands are a little bit tied. And you also do get to the point where the systems, a system as large as our system is designed to protect itself and to further itself. And until we get past that point, and until families are joined with the practitioners and with everyone saying like this isn't working. Whether that means that my job that is right now, that is specifically to service this population for this issue, maybe needs to change into something else or needs to become part of something else. So the piece of self-interest of the system itself needs to be addressed. And I think that's where the policy piece comes in. And we need, families have been advocating for a long time, and we need other voices to come alongside and to advocate as well, saying, this is a crisis and we need to support families because it's more from an American perspective, but like Dr. Ross Green talks about, the school to prison pipeline, right? And it's like, if we're not dealing with these issues as a society, it's the outcome is not going to stop when the kids turn 6, and it's not going to stop when they turn 16. And it's not like it's going to go on. And, really, if we think about it from an economy perspective, the amount of dollars that could be saved by supporting families at the beginning is huge. The amount of money that's being thrown at mental health right now, but again, into those silos, into those voids, it's kind of like a drop in the bucket.
Thanks very much, Corinne. Sorry. Dr.
I was just going to say, yeah. So
Yeah.
Connecting to Corinne, and I was reading, the distractible part of me was reading all the questions in the Q&A and trying to sort of, synthesize some of that and connect it to what we're saying. And what I'm reading is a lot about, differential access based on all of the factors that we've talked about and questions of that. And, how does that get addressed? And policy, and what can people do today? So Corinne, I think between the two of us, what we're saying, from my point of view, what I'm understanding and saying is that we have to start recognizing who's at the table and who we're missing. Because in that, when an agency starts to look around and see who's at that table, despite them being well educated and well-meaning, they have biases, that it's not allowing them to understand what a different experience is for somebody that's at your table or not at your table. So what can agencies do? They can start to address who they're not seeing, who's not present, and who's not represented. And then the other thing that you're talking about, Corinne, there, the prison, the looking at the reading scores in elementary school and being able to predict your prison populations is American data, but very true in Canada. And so there was a question in the chat about low expectations in Indigenous cultures that extends to racialized cultures. And I think what we're, as the Canadian Paediatric Society, what we're starting to do is encourage pediatricians to be able to talk about this, right? And as that comes around with that idea of talking to parents about real things in those ways that it's not bad if your kid is watching 9 hours of television a day. Okay, it's a problem, and what's that about? It's not because you are an awful parent, but what is that about, right? And so it's to answer those questions, it's about us breaking down the meaning of what mental health is, breaking down our biases about that, breaking down what parenting is and what it's about, and our biases about that, because, we've gotten rid of parenting capacity assessments, because we realize we actually don't know what that looks like and what is good enough parenting and what is, the bias in that. So I think in sort of to vaguely answer some very, very detailed questions there, for me, Corinne, you can agree, disagree, it's about breaking those things down to understand at the core what our agency, what our service providers understand that to be, what we see, what we don't see, who we see, what we don't see, and how do we come together around little people and families.
Thanks very much, Dr. Johnson. And also been looking at the questions and wanting to pose a few of them to you before we wrap up. And maybe, Corinne, if I could turn to you to speak to this. One of the questions is around, how to support mental health among 0 to 5-year-olds, and how to understand what a mental health issue among 0 to 5-year-olds looks like. How do we kind of get a concept of mental health in early years? And I wondered, from your lens, I know Dr. Johnson would be able to answer this from a clinical perspective, but from your lens, what does mental health in those early years look like? What do you think are the key aspects to be looking for, celebrating, understanding? I can ask you that.
Yeah, so it's hard to define, right? Because we're still not extremely comfortable with the idea of, when we say mental health issues in children 0 to 6, right? Like, what does that mean? So the way I tend to think about it and frame it when I'm talking with parents is that, we all have mental health in terms of mental wellness, right? So yes, there are times when, a young child is going to meet the threshold for a clinical diagnosis, but as opposed to jumping that gun, maybe we can start with, again, the connectedness, the attachment, gentle parenting, moving, helping people move away from, corporal punishment in terms of parenting, to be inviting them to really, understand the behavior and see, like, what is my child trying to tell me in this behavior, and be able to respond to them with that, like we've talked about, with that co-regulation, right? So again, it's just about that relational piece, right? And a lot of parents, sometimes you think, oh, I'm a parent now, I should know how to do this, but it's actually not true, right? Like not everyone knows how to parent, not everyone was taught how to parent, and there should be no shame and no judgment. When you go to even your GP and say, look, I'm really struggling with this, we need that family doctor to be able to say, okay, well, here are some resources in the community that can support you with that. Especially if we're talking about rural communities and isolated, like everyone needs to have the resources in their own community. That's really important.
Okay, great. Thanks very much. So we're running close to the end of time. So I'm just going to ask you if there's anything, we had a question around if you could choose one thing that programs and agencies could do that would make a real difference today, what would that be? Just in a snapshot, what's the sort of one thing that you want to emphasize before we close the webinar?
For me, it would be encourage families to take a collective breath. Academically, little people will catch up. Behavior is communication, and let's look around and see who's not at the table, who's not represented, and draw together, because infant 0 to 5 mental health looks like many different things, and it becomes a concern when it's affecting the functioning of the little person and the family unit.
Okay, thanks very much, Dr. Johnson. What about you, Corinne? The one thing that you would want to close with?
The one thing I would want to close with is really just to the parents and to the practitioners that are dealing with them on a day-to-day basis is that parents need to trust themselves, and they need to be able to trust that, if something is not right, that, they're accurate in that assumption. And if they need support and they're not getting it from one place, maybe unfortunately you have to advocate for yourself and for your family and for your child, and you have to go to another place. And for practitioners and policy makers and whomever it may be, would just simply be to listen, right? To listen to the families, to listen to the parents that are coming in, and to be understanding from their perspective what is happening, and not putting some of those, like we talked about, putting those biases on and saying, well, that's not what I'm seeing in this situation, right? So just to be trusting the families and the children, and that they know what's going on in their own bodies and in their own families, and make that your jumping off point.
So trust and listening, really powerful messages. So we're out of time. I just have a few bits of information to share before we close things off. And I believe as well that there's links to a survey, a follow-up survey, so you can give us some feedback about what worked well and what less well in webinar. It's been shared in the chat. We've got some links up here to the Mental Health Commission of Canada's COVID Resource Hub. So this brief on early childhood mental health, and other ones on corrections, on rural and remote communities, on impacts of the pandemic for people living with serious mental illness, can all be found at this link, as well as a whole wealth of tip sheets and resources for more kind of practical applications in people's families and communities. We also have the link to the Canadian Paediatric Society website, Parents for Children's Mental Health, and My Neurodivergent Child. And then I believe the last slide just provides some contact information. Thank you very much for your participation today and for your interest in this topic and in this work. And thank you to our panelists, Dr. Cassia Johnson and Corinne Bridger. Really appreciate your time today. And if you have any follow-up questions, Brandon Hayes' email is here on the slide. So thank you, everyone. Stay safe and have a wonderful day.